So, ito, Special Health Fund serves as a repository of all health funds of the integrated system consisting of provincial, municipal, and city health budgets, PhilHealth payments, DOH grants, and development partner support, among others. So, at least maganda siya kasi, ano to, may isang fund lang talaga. Endowment, para siyang malasakit center na scheme but not necessarily malasakit scheme. Kasi yung malasakit, nakafocus siya sa hospital. Okay. Magkano kinuha ang pera? Okay. So, the end point is that the funds pooled at the network level, no? So, yung worry mo, Dr. Pidere, we will open a separate depository account for the special health fund. They will set up books of accounts and financial reports. There will be a network-wide enterprise resource planning. So that is focused on planning and budgeting, allocation of resources, budget execution and disbursement, monitoring and accountability. So the output indicator is, again, what is the difference between an output and an outcome? So the output is you are accomplishing the objectives of that specific plan. The output is you are answering the specific activities, while the outcome is you are answering the objectives. Impact is you are addressing the goal. Okay. So for every inputs, there will be a corresponding output. So the output indicator is titignan yung current operating budget, yung consolidated book of accounts, and consolidated financial statements. While the outcome indicator is cost efficiency. Kailan mo matatawag na cost efficient ang particular health plan? So nakikita mo, for example, at this year, 100%, next year, 80%, the third year, 60%, until hindi na dependent doon sa mga binibigay ng outside sources. So para kang gagawing economic enterprise. So the mechanisms of the special health fund will still be undergoing the budget cycle. So again, the budget cycle is composed of 4: planning and budgeting, allocation of resources, budget execution or disbursement, monitoring and accountability. Ganun-ganun, ikot-ikot lang. Pag ano naman yan, hindi ilalagay, for example, hindi ito mga wish list. Gusto ni Mayor maglagay ng, for example, gusto niya maglagay ng CT scan. Check mo yon versus nasa plan ba yon? Nailagay ba yon sa plan on the next ano? Hindi ka basta makakagamit ng special health fund. It should be according to the plan, budget, allocation of resources. For example, 10% will be given to, how many percent will be given to capital outlay? How many percent will be medical equipment? How many will be given to the laboratory? So, these are the stages of the budget cycle. How many again? There are 4. In the planning and budgeting, there will be a provincial or city budget process. Ang Tacloban have a separate, para siyang province kasi highly urbanized, no separate process at the component LGU level. So meaning, kapag ikaw ay component city, you are the same with the province. So the special health fund will be managed by the provincial government. Tacloban being the fund will be managed by the city government, no? And the third party will do the enterprise or corporate budget process and manages the special health fund at its corporate budget. Pagdating naman sa virtual, kasi may ano yun, sabi nila, yung real or full enterprise or virtual, ano lang siya, kumbaga, yung nakikita mo na mga books of accounts, no? So, there will be a network, no? Network ng mga ano yan, ng mga facilities, possibly if it's just they can maintain their own special health fund. And the allocation of resources, the province or the highly urbanized city to allocate shares to individual facilities. For example, tertiary, ilan ang ibibigay doon? Since all private will only accommodate 10%, maghahati-hati yun. But if you go for an enterprise, no, there will be a management office, no, that allocates to individual facilities. Pag sinabi mo namang virtual, parang meron lang nagse-set up na hindi naman siya enterprise, the province allocates share to individual municipalities in the network. The second is budget execution or disbursement. The scale economies both through central procurement and single pricing policy. Parang nakikita na natin dito, mawawala na yung iba't ibang mga pharmaceuticals kasi magkakaroon na siya ng central procurement that will be distributed to all. No? Lang naman ng nito is yun na nga, kaya ngayon medyo mura yung gamot kasi pag meron ng central procurement, kung sino na yung mananalo. However, pwede rin itong subject to political kung sino ipapanalo nila, di ba? So, pagka sa monitoring and accountability, either the real or full, there will be a single accounting and auditing system. Sa enterprise, the same, all of them. Kaya lang, pag itong virtual, no, ibig sabihin, mix siya, it will be under the Department of Budget and Management. Okay, they will always follow government accounting rules and regulations. So the same, I think I have mentioned this, 3-year local investment plan for health, the LIPH, and then annual investment plan, work and financial plan, and APP, annual procurement plan. So your annual operating plan will be based on this, no? So ang dami-dami, kaya nga ngayon, I think it was Ateneo de Davao, and Ateneo School of Medicine. Their Doctor of Medicine already has MBA for Health, Masters in Business Administration for Health. Because of this, kailangan na intindihan din natin itong mga iba't ibang uri nito. Although sa inyo, hindi pa masyado to ma-appreciate. We are just looking into the system, the health system in the future. Okay? To support the integration, PhilHealth shall implement a prospective global budget payment to select the implementation sites. AIS is Advanced Implementation Site who meet the criteria. No? Ano ba yung global budget? No? Pag sinabi nating global budget, the Universal Healthcare Act provides legal basis for provider payment shift. No? PhilHealth shall endeavor to shift to paying providers using performance-driven, close-end prospective payments based on disease or DRG, diagnosis-related grouping. So dati kasi nagbabayad ang PhilHealth via per specialist or per ilan yung iyong professional fee to the facilities. This time they are looking forward into meron ng parang katulad sa ibang bansa, they are basis on diagnostic related groupings. For example, pneumonia 5,000 halimbawa, you cannot go beyond 5,000. Kung ilan yung para sa professional, yun lang din yung ibabayad sa iyo at saka doon sa facility. Okay. Anong kaibahan pag prospectively or retrospective of care? Yung fee for service, halimbawa, nag-opera ka, di ba? Nag-opera ka, kung ano, tapos ipapa-reimburse mo yon, doon ka makakakuha ng reimbursement. Pero ito, sa prospective ano na, kung ano yung inputs mo, may output yan, at babayaran ka based on the DRG, dengue, halimbawa, dengue, I think they are implementing it now, dengue probable, okay? So, yung inputs mo doon, based lang sa output ng makukuha mo, based on the diagnosis, yun lang yung babayaran ng PhilHealth. Okay? Yan. So, prospectively, determine a set amount for a specified time period. No? It covers expenditures for agreed upon set of services. Provider has control over how the budget is spent. Nako, pagka nagkaganito dyan, talagang makuri na, no? Kaya dapat very good yung planning ng lahat ng ito. If not, baka it will just die as a natural death. Okay? Ang maganda lang sa global budget, no? It promotes fiscal autonomy and efficiency. No more waiting time for claims processing kasi nakaano na siya naka-diagnostic groupings na siya. Lessens transaction cost, eliminates reimbursement delays. It enables strategic use of funds for improved care coordination and allows early planning and big investment. So, global budget promotes behavioral change in providers. Cost control as the priority. It promotes cooperation between providers. It enables a stronger referral system. But the downside of this, it may promote artificial spending and may promote under-provision of services and not always linked to performance indicators. Kasi nga, wala na siyang reimbursement kung ano lang ito na case. Kaya lang, pwede mong ilagay minsan, pwede mong lokohin. Ito yung hindi siya pneumonia severe, pero nilagay mo siyang pneumonia severe. So, papaano how can you address those promotion of artificial spending and under provision of services? The provider can set and agree on clear performance indicators, both in the financial and service delivery and link with succeeding payments. And you can provide complementary guidelines as, for example, CPG, adherence to CPG as basis for audits, monitoring, and evaluation. Who are eligible? Okay. Advanced implementation sites, kasama to with established special health fund may start receiving the global budget plus commitment to provide defined outpatient and inpatient health services. Strictly implement NBB is no balance billing in at least 90% of beds and fixed co-payment in most 10% of beds. So, ibig sabihin, 90% of beds of the public hospital and 10% of the private, no? You need to develop a IT system that will enable compliance to the data requirements and electronic submission and dedicate required personnel. So, hindi mo pwedeng gamitin yung mga existing personnel. There should be a different personnel that will work on this para yung Dr. Pedere is quite apprehensive ito na mga personnel na matatapuran, trusted personnel. How much? Okay. Option 1 is the capitation for outpatient. Hindi siya capitation, capitation. So, yung capitation for outpatient is about, I think, 1,500 per patient na nandun sa outpatient and plus global budget for inpatient plus network contract. Pagsasama-samahin siya, it will result to healthcare provider network contract. Okay? Or another option is that single rate global budget. So inpatient plus outpatient capitation will result to healthcare provider network contact. Pero I don't know what will happen if we implement the option 1. Mas maganda yung, for me, mas maganda yung option 1 kasi nakikita mo yung distinction. Unlike dito sa isa, pinagsama siya, then you have a healthcare provider network contract. So, the good thing with global budget is there will be an increased capitation both for the primary care and inpatient services. So, kung naka-enroll ka, no, magkakaroon ka ng capitation and then yung utilization. Kung halimbawa, you are going to maximize for a year kung kailan ka ma-hospitalize. Pero, ang difference nito, we should be investing on primary care services. Okay? Hindi pwedeng hospital-driven. So, ito, this is just something na you can use different approaches. So, historically, pwede yung ginagawa ngayon na kung ito yung, you will just do a historical data for the past 10 years. Or, you can do the capitation approach. Kaya lang, the problem with capitation approach is the spending is dictated by the population that they serve. So, pag nasa urban setting ka, mas makuri ito kasi mas maganda at the same time, it's difficult kasi, the population group in Tacloban is very heterogeneous. No? And the challenge is the complexity of the data and the system. The normative approach is external rate setting approach is applied to unit price. So meaning, for example, for this amount, you will just, meron ka lang tinatawag na 0.6 something. Or yung tinatawag na ilan ang points na ibibigay mo or percentage na ibibigay mo for the specific disease. Okay? Or sa specific services na ibibigay mo. But we can do mixed approaches if we want to, depending on the health board. Okay? So, dati, 500 lang pala dati. So, they wanted to increase it into 1,000 pesos per individual. The primary care package. Pagdating naman sa utilization, what they are trying to, kasi pag sinabi mong utilization, sa 1 year, hindi siya, ilang beses mo lang siyang pwedeng magamit. Unlike in the insurance, no, na pwede, yung we want kasi to, what you call the term, meron kasing gatekeeping dapat. Doon sa gatekeeping, siya yung nagmo-monitor ng pag-utilize ng paggamit mo. So, sino ba dapat kung, let's have, for example, kung age 25 to 40 to 50, 'di ba, madalang kang na-hospital. So ikaw gagamitin mo yung budget, yung capitation mo for primary care services. So that hindi siya underutilize or ma-overutilize. Any question? Ang ano kasi, ang difference if you are, for example, yung private insurance, you can use your insurance anytime. Pero kapag nandun ka na dun sa etong network, you are allowed, for example, you go first to the primary care physician, then you have to utilize yung ano ba yung mga cessation, pwede rin yung family planning, gusto mo ang implanon, yung mga yon. Unlike sa insurance, kaya ang nangyayari, nalulugi because the tendency to overutilize. Question? So more or less, ang universal health is a very good, it's already a law, wala tayong magagawa doon. We just have to ensure that of the service delivery, the governance, finances, and the regulatory will be feeling ko naman, hindi naman siya magiging subject to, corruption. Pero hindi natin alam, PhilHealth is still under under scrutiny right now. Any thoughts? Anyone has a thoughts? Hello, wala kayong question? Wala. Pahingi naman dyan ng thumbs up kung wala kayong question. Or dahil boring ang primary healthcare. Ang universal healthcare. Actually, siguro as an assignment, you can read the universal healthcare law and kindly read it because by next week, we will now shift into as the essential public health services. Kasi hindi natin, magsa-start na tayo sa essential public health services after the universal healthcare and different health system. And then after the essential public health services, we will go to health promotion. So hopefully, by January, we already have face-to-face. You can now make your own health promotion activity. Kung NBB lahat ba ng may PhilHealth sa class? NBB, no balance billing, what is existing right now, meron pang certain diseases lamang for the no balance billing. All hospital should sana no balance billing. Pero ang nangyayari, hindi talaga. But for public hospital, it is really no balance billing. For certain diseases only, hindi pa lahat. Thank you for that question. Meron pa? Wala na? Okay. So with that, thank you very much. And ngayon medyo boring pa. Pero very important ang universal healthcare. As I have mentioned, it will be tagal pa no, no? Second year, third year, clerkship, internship. Pero ako, I believe that sa siga, sipag at tiyaga. Sa sipag at tiyaga, you can make it. Okay? So, thank you very much and have sandali. Have a weekend. Doc, magpapa-clarify lang ako sa assignment namin ng presentation. Meron ba kayo assignment na presentation? Wala pa. Meron ba? Wala pang assignment. Yes, Dr. Cindy. Yes?
You mentioned Doc last time.
For January pa ata, Doc, yung assignment.
January pa yon. Oo. Kasi magiging that will be part of presentation after we discuss the essential public health services. Parang ilang meeting na lang tayo. Meron pa tayong meeting kasi, for example, if you know the public health diseases of public health importance, magkakaroon na kayo ng idea kung ano. That will be for January. So gagawa kayo ng mga jingle, pwede rin. Gagawa kayo ng simple, what you call this, 3-minute. This is talagang 3-minute lang siya. Maximum of 5 minutes. Ana? So take care ha. COVID-19 is still here. So we have cases. Ang problema lang, per family na yung naapektuhan. So ibig sabihin, social gathering and is a very big factor in the transmission of COVID-19. With that, thank you very much. Mamuji loves you so much. And I will miss you tomorrow. Pero I have to study also. Kasi baka hindi ako pumasa sa competency exam namin for family medicine. Love you guys.
You can do it.
Thank you, Doc.
Thank you, Doc.
Amen, amen, amen. Thank you.
Good
So
luck,
sino man
Doc.
nagsabi
We
ng
love you, Doc.
salamat? Oo.
Good luck, Mamu.
Good luck po, Mamu.
Salamat. Oo.
Good luck po.
Good luck, mabilis lang. Actually, hindi ako nakakatulog kasi mayor mo ba naman ang mag-positive? So, for 2 nights lang ako kakatulog kasi symptomatic. So, medyo challenging siya but thank God we're able to he's okay. Mataas ang autosat, okay naman yung kanyang blood pressure. With that, thank you so much. God bless you. Salamat sa lahat ng nag-PM. Thank you. I love you. God bless you.